Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy life. My name is Dawn Liz Powell, Medical Editor at MIMS Learning, and here with me is our Deputy Editor, Rhiannon Ashman.
Hello.
Okay, Rhiannon, question for you. According to pop goddess Miley Cyrus, nothing breaks like a what?
Okay, I know Miley Cyrus came in like a wrecking ball, and I'm assuming nothing breaks like a heart.
You are indeed correct. Nothing Breaks Like a Heart is the title of the 2018 song that Miley did with Mark Ronson. We won't be playing a clip of the song because that would be very expensive. But the gist of the song is how a breakup of a relationship can leave a scar on your heart.
First you out yourself as a Bridgerton fan in our episode on emergencies, Dawn. Now you're outing yourself as a Miley Cyrus fan. I didn't realise you were such a connoisseur of popular culture.
I am a woman of many layers. Anyway, the song does tie in, sort of, with the theme of this podcast. That is, how do our emotions affect our heart? The physical one, I mean, that beats in our chest, not the metaphorical one that apparently, according to Celine Dion, will go on despite the heartbreak. There is actually a condition called heartbreak syndrome or stress cardiomyopathy, and we do have a module on it on MIMS Learning by Dr. Hani Ali and colleagues. Rhiannon, you had a look at this module. What did it say?
Okay, heartbreak syndrome is acute left ventricular systolic dysfunction that occurs in the absence of coronary artery disease, or CAD, or another underlying condition that could explain the dysfunction. Its link with emotion is because a stressful trigger, such as the loss of a loved one, was identified in most of the first cases that were reported. So while extreme negative emotions, such as stress and grief, are linked with it, so are positive emotions. For example, extreme joy has been cited as a trigger for happy heart syndrome. Several physical triggers can also lead to the syndrome, including acute medical illness or major physical trauma. And we should also clarify that the correct medical term for heartbreak syndrome is takotsubo syndrome. The word takotsubo refers to the fact that in people with the syndrome, the left ventricle resembles a traditional pot that Japanese fishermen historically used to catch octopus. So takotsubo literally means octopus pot. Plus, syndrome is preferred over cardiomyopathy because the term cardiomyopathy implies a primary disease of the cardiac muscle, which is not the case with takotsubo syndrome.
Well, thanks for that info, Rhiannon. I'm not going to go into too much detail about the diagnosis and management of the syndrome because that is covered in depth in the module. But briefly, its presentation is similar to that of acute coronary syndrome, or ACS, so chest pain and breathlessness. In fact, takotsubo syndrome accounts for 2% of all ACS presentations in the Western world, and the vast majority of cases are in women. According to the module, 6 to 10% of all ACS presentations in post-menopausal women are actually takotsubo syndrome.
So is there some link between menopause and takotsubo syndrome, or is it just a factor of age?
Yes, as well as the emotional and physical triggers we've mentioned, menopause, mood disorders, autonomic nervous dysfunction and malignancy are predisposing factors. However, we should point out here that historically, ACS and CAD are underdiagnosed in women. Another module we have, coronary artery disease in women, does explore this issue. Therefore, before diagnosing takotsubo syndrome in a woman or a man, it is vital to ensure that ACS or any other underlying cardiac condition is not the cause of the symptoms. If the syndrome is confirmed, medical management can be used to reverse the left ventricular dysfunction. However, this does not mean that takotsubo syndrome is always benign. Dr. Ali et al. Note that the syndrome in severe cases can lead to left ventricular outflow tract obstruction and associated mitral regurgitation. Patients can also present in cardiogenic shock, and the syndrome can lead to sudden cardiac arrest.
So if takotsubo syndrome is sometimes mistaken for ACS, can stress also trigger ACS?
Well, according to US physician Dr. Rachel Lambert, stress can lead to an ACS. In an article on Yale Medicine, she's quoted as saying that in people with existing CAD, the surge of adrenaline that can come with stress or extreme emotion can sometimes contribute to plaque rupturing. resulting in a blood clot that could grow large enough to block blood flow completely and cause a heart attack. Dr. Lambert also says that stress can exacerbate the symptoms of other existing heart conditions, such as an arrhythmia, like atrial fibrillation.
But the important thing for us to consider, of course, is what GPs can do to help a person who is stressed. So addressing the underlying causes of stress might be beyond your control and perhaps beyond the scope of the 10-minute appointment. But if a patient has opened up to you to say that stress is causing them problems, this may be a good opportunity to call on social prescribing. You might remember, Dawn, I spoke to Monica Bolton from the National Academy for Social Prescribing last October for this podcast. And one of the things that she said was that link workers are able to give the time needed to really understand not just the symptom that a patient might be presenting with, but what the cause is and where it might be coming from. And of course, there are also ways that patients could be supported to manage their stress better. So we do have a free module with resources for supporting people to improve their mental well-being. And that says that, according to NICE, guided self-help should be offered to people with less severe forms of depression. So GPs could perhaps also suggest guided self-help to people who are reporting that they're stressed.
Yes, so just to note, NICE describes guided self-help as printed or digital materials that follow the principles of guided self-help, including structured cognitive behavioural therapy, structured behavioural activation, problem-solving or psychoeducation materials. These can be delivered in person, by telephone or online. Of course, patients in England, aged 18 years or older, can refer themselves directly for talking therapies without contacting their GP. However, they do need to be registered with a GP to access talking therapies. If they prefer, they can ask their GP to refer them. But back to the topic in hand. So we've talked about how stress can affect the heart in the short term, but what about the long term?
A study in Nature Reviews Cardiology found that stress led to a small increased risk of coronary heart disease and stroke. It also found that in people who already have heart and circulatory diseases, stress was linked with worse outcomes. However, as the British Heart Foundation says, people who are stressed are more likely to turn to unhealthy habits, such as eating the wrong foods, smoking or drinking too much. So the impact could be more indirect. Chronic stress could lead to an unhealthy lifestyle that could then lead to people developing risk factors for cardiovascular disease, such as high cholesterol or hypertension.
Okay, so let's focus now on the risk factors you've just mentioned and how they can be addressed. GPs and other primary healthcare professionals, in reality, cannot do much about the fact that patients are under stress, other than perhaps, as you've mentioned, signpost them to resources that can help them to manage stress. But addressing risk factors for cardiovascular disease is, of course, very much something that GPs can get involved in.
Yeah.
So for the rest of this episode, let's imagine we have a patient who is chronically stressed. Because of that stress, they lead an unhealthy lifestyle, and consequently, they have developed risk factors for cardiovascular disease. Their GP is going to want to assess their risk and help them address their risk factors.
Okay, so can you talk me through the first bit there, the risk assessment itself?
Yeah, we have a module on the NICE guidelines on cardiovascular disease risk assessment and reduction, and that talks about risk assessment tools. It says the QRISK-3 calculator should be used in favour of the QRISK-2. Compared with the QRISK-2, QRISK-3 has additional risk factors and therefore may provide better risk prediction for certain groups. For example, people taking corticosteroids or those with severe mental illness. There's actually a link to QRISK-3 in the module, and I had a quick check of my own risk. And apparently I have a 1.6% risk of having a heart attack within the next 10 years, which I am okay with.
I did mine too, actually. I have a risk of 0.3%.
Yeah, but that's because you're not the one turning 45 this year.
Yep, the score of more than 10% would put you at increased risk. So a score of less than 10% is relatively good. However, if a person has a QRISK-3 score of less than 10% and or they are under 40 years and have CVD risk factors, for example, if they're a smoker, then clinicians should consider using a lifetime risk tool. And NICE recommends QRISK-3 lifetime.
Okay then, so say the GP has identified that a person is at increased risk of cardiovascular disease. How do they go about addressing those risk factors?
So the module says that the findings of the QRISK-3 lifetime score can be used to inform discussions about risk and to motivate lifestyle changes. Specifically, both people at high risk of CVD and those who already have established CVD should be encouraged to eat a cardioprotective diet. So this means that the total fat intake should be 30% or less of the total energy intake, and saturated fat intake should be 7% or less of the total energy intake. And where possible, saturated fats should be replaced with monounsaturated and polyunsaturated fats. However, of course, people might need support to change their lifestyle. So if necessary, you could refer them to exercise referral schemes or weight management services. CVD risks can be assessed again after lifestyle changes have been made or attempted.
Yeah, so in fact, lifestyle changes should be discussed and attempted before statin therapy is initiated. I think that just makes me think of my interview I recently done with Professor Alex Miras, and he was talking about supporting people with obesity. And I thought he mentioned a couple of things which I think were quite interesting. First of all, that when the person comes to you, and this is just in the context of wanting to address their weight, they've probably already tried diets and other things. So bear in mind that when they're coming to you and asking you for support with weight management, they are things they've already tried and they haven't worked. Yes, discuss lifestyle changes and support them with it, but don't keep on with them or don't keep trying to get them to do the same thing if that hasn't worked. But going back to this module here that we're talking about cardiovascular risk reduction, if a person still has a 10-year Q-risk-3 score of 10% or more after lifestyle changes have been made and or not worked, patients then can be offered 20 milligrams of atorvastatin. However, statin treatment with 20 milligrams of atorvastatin should not be ruled out in those with a 10-year Q-risk score of 10% or less if they have an informed preference for a statin or their risk of cardiovascular disease may be underestimated. Importantly, this recommendation only applies for the primary prevention of cardiovascular disease, while those with established cardiovascular disease should also be offered lifestyle advice and support. There's a discussion of such changes should not lead to a delay in initiating statin treatment. People with established cardiovascular disease should be offered atorvastatin 80 milligrams. However, a lower dose can be considered if there is a risk of drug interactions, there's a risk of adverse events, or the patient would prefer a lower dose. Though, just to note, a lower dose would be off-label in this context.
Okay, so let's look at targets. For primary prevention of CVD, the aim is for a greater than 40% reduction in non-HDL cholesterol. And for secondary prevention, in line with the QOF, GPs now have to aim for a target of an LDL cholesterol of 2.0 millimoles per litre or less, or a non-HDL cholesterol of 2.6 millimoles per litre or less. NICE says to measure a full lipid profile 2 to 3 months after starting or changing lipid-lowering treatment. If lipid targets have not been met for either the primary or secondary prevention, NICE states that adherence and timing of dose should be discussed with the patient, adding that opportunities should also be taken to optimise adherence to diet and lifestyle measures. If the patient is not already taking a high-intensity statin at the maximum tolerated dose, a dose or intensity increase should be considered.
To expand on that, if the secondary prevention target has not been met despite the patient being on the maximum tolerated dose and intensity of statin treatment, additional lipid-lowering treatments can be considered, following discussion with the patient about the risks and benefits of those therapies. The NHS has produced quite a detailed algorithm on which statin therapies to use and in which order. I'm not going to describe it here, but there is a link in our module on the NICE guidelines for risk reduction. In another module we have on achieving cholesterol targets in primary care, which is actually a conference report of the 2023 PCCS annual meeting, Professor Derek Connolly says that combinations should be used to bring cholesterol down in the same way that they are used to bring blood pressure down and they are used to manage type 2 diabetes.
You mentioned hypertension and type 2 diabetes there, Dawn, and we should point out that we also have modules on these topics, lots of modules actually, and we have a module and a podcast episode on obesity in adults, which you referenced earlier. All three of those are risk factors for cardiovascular disease, of course, individually and collectively, that could develop as a long-term consequence of someone living with stress, either directly or indirectly through them leading an unhealthy lifestyle as a coping mechanism. And this podcast episode's been fascinating to record. Thanks for suggesting the topic, Dawn. But there's no doubt that talking about the negative impacts of stress can make you worry about your own stress levels. And what's more, we know that general practice can be a stressful place to be at the moment. So I wanted to finish off this part of the episode with an invitation to our listeners to take care of their own mental health. And one way you might want to do that would be to have a watch of our Wellbeing Masterclass featuring a presentation by resilience trainer Dr. Farnaz Sharif. And this provides practical methods to reduce stress and promote well-being in healthcare settings, including in primary care. It's available on demand on our website, and we'll link to it in the podcast notes.
Thanks for that suggestion, Rhiannon. I think the old adage applies there, doesn't it? Physician, heal thyself. And thanks for talking about this topic with me today. Let's just have a quick review of what we've learnt. So, extreme emotion can trigger takotsubo syndrome, which is acute left ventricular systolic dysfunction that occurs in the absence of coronary artery disease or another underlying condition. People who are stressed are more likely to turn to unhealthy habits, such as eating the wrong food, smoking and drinking too much. Therefore, chronic stress could lead to an unhealthy lifestyle, and that could lead in turn to people developing risk factors for cardiovascular disease such as high cholesterol or high blood pressure. GPs and other primary healthcare professionals in reality cannot do much about the fact that patients or themselves are under stress, other than perhaps signpost them to resources that can help them to manage stress. But addressing the risk factors for cardiovascular disease that developed either directly or indirectly as the result of chronic stress is something that GPs can very much get involved in. Don't forget that you can claim CPD hours for listening to these podcasts, and there are plenty more on the MIMS Learning website. Thanks for listening. We have been the MIMS Learning editorial team, and this episode was produced by Till Owen. Keep listening for a taster of our next episode, where Pat Anderson will be talking to Dr. Majid Kazmi about hematological cancers.
You could have a patient who's clearly got a form of chronic leukemia, but that is something that is not going to need treatment, maybe never need treatment. But you send that patient on a 2-week wait cancer pathway and you're scaring that patient, making them worried. Whereas if you got on the phone and spoke to the hematologist and said, how urgent is this? Do I really need to send this patient in now? You could avoid a lot of anxiety.